hepatitis B. And I'm truly hopeful that the dental schools of this country, the hospitals of this country, will be very insistent that all dental personnel coming into the dental care setting will seek immunization against this very serious disease. In 1983, the causative virus, human immunodeficiency virus, or HIV, was isolated, and in 1983 a test for the antibody was developed. I think those of you who follow the newspapers know that the ownership, the rights to these two discoveries, that of the virus and that of the test for the antibody, have been subject to very intense legal battles, and it is still not settled. It was now known in the mid-19 or early to mid-1980s that HIV infection, AIDS, was spread by blood and two other routes, which I will show you on this slide. We had learned by the early 1980s that people who received blood and blood products were coming down with this terrible new disease. The routes of transmission are very simple. They're sex, blood, and perinatal transmission. Let me show you one other important comparison, and that is a comparison of the routes of transmission of HIV and HBV. And this is an interesting comparison because it shows some very important similarities between these two viruses. HBV is transmitted through sexual contact, as is HIV. It is transferred through blood and blood products, as is HIV. HBV is transmitted perinatally, as is HIV. But here are two significant differences. HBV has been demonstrated to be transmitted through saliva. HIV has not been demonstrated. Despite what the OSHA standard says about saliva in dentistry, there has been no recorded transmission of HIV through saliva, and there has been no transmission of HIV in the numerous studies of household contacts, but there has been transmission of HBV in that context. I want to assure you, and it's very important to remember this, you don't get HIV from door handles, from pencils, from close contact, from sneezes, from shared clothing, or even shared plates. Now let's look at how this disease has grown. This is a very shocking curve. We start down here with the 5 young men in Los Angeles in 1981. And look at the shape of this curve. This is a curve showing exponential growth of a disease. We are at the point in 1992, which would be out here, of having 215,000, roughly, cases of AIDS in the United States. There are 8 to 12 million in the world, and there are 1 million probably who have HIV infection in the United States. Another way of looking at the disease, and one which offers not a great deal more comfort, is to ask ourselves, when did the first 100,000 cases appear? In the first 8 years of the epidemic. When did the second 100,000 cases get diagnosed? In 3 years. And when will the next 100,000 appear? In the next 2 years. Another way of looking at this is to ask ourselves what segments or sectors of the population are afflicted by this disease. Now, everything that I'm saying is a movable feast because the disease changes its face daily. The numbers change, the characteristics of the patients change. When we started in 1981, all of the patients fitted into this sector, which is homosexual, bisexual males. Then we added this green piece, which is IV drug users. And then we added this pale blue piece, which is homosexuals who also use IV drugs. So together, the homosexual, bisexual males, the exclusive IV drug users, and the homosexuals who also use drugs occupy 86% of this pie. There are two segments of this pie that are particularly interesting and that are growing, or one is growing, one is not. The purple, mauve, violet sector, if you wish, is heterosexual contacts. And for a long time in the progress of this epidemic, it was felt that the heterosexuals were kind of out of this. Unfortunately, they're not. This is mostly women. These are mostly women who have been infected by males coming from this part of the chart, or the pie. And this part is growing very rapidly. The second sector that I would call your attention to is the yellow wedge. That is disease of other or undetermined origin. This has remained fairly steady throughout the 11 years of the epidemic. It represents 6% of the patients. That's a lot of patients. 6% of a million, I believe, is 60,000, and we don't know how they got the disease. Now, the decade-long, more than decade-long epidemic has been marked by two defining events. The first occurred in 1987 when Dr. Robert Klein, an infectious disease specialist at Montefiore Hospital in New York, using a population sample from the ADA, announced that a dentist had probably acquired his HIV infection occupationally. He had no risk factors for the disease. He had been happily married to one woman for 12 years. He had, his use of gloves had been haphazard. He explained that he was an ardent fisherman and that his hands were frequently cut up by burrs or hooks from his tackle. Now, this first case of possible patient to provider transmission had a number of consequences for the profession. It raised to a new high dentists' anxiety about treating HIV-infected patients. There was a significant change in the use of infection control techniques, and we know this from data that we have, and we have evidence that the number of percutaneous injuries plummeted between 1986 and 1988 when we surveyed dentists' attitudes and behaviors. This finding gives us real optimism that in the face of a crisis, we can see important changes in behavior. Now, the second defining event is this one, the report by the Centers for Disease Control in 1990 that a dentist with AIDS had possibly infected a young female patient. She was decorously labeled as patient A at that time, but we know very well that she was Kimberly Bergalis, now regrettably dead of her disease. She had no apparent risk factors for HIV, and she had had an invasive procedure performed by this infected dentist. The invasive procedure involved the uncomplicated removal of 2 maxillary molars. Months later, the dentist, named Dr. Acker, as you know, informed his patients through the newspapers that he was dying of AIDS, and he recommended that they go to their physicians or to testing facilities and be tested for their own peace of mind. Eventually, about 1,000 patients presented for testing. This is probably not his entire patient roster, and this is what they found. The dentist, of course, is up here. He had risk factors for AIDS or for HIV infection, and 7 patients were found to be HIV positive. Through very sophisticated and extremely expensive viral sequence matching, in which the DNA from the dentist, and before he died, he had allowed a single blood sample to be taken, and using that blood sample, they were able to take his virus and try to match it up with the viruses found in patients A, B, C, etc., the 7 HIV-infected patients. The DNA was related in the case of 5 patients, but in 2 of the cases, there was no match in the viruses, and there were risk factors for HIV. Now let's look just at the 5 patients whose viral DNA matched that of the dentist. These are patients A, B, C, E, and G. Here's what happened to them. Patient A, Kimberly Bergalis, had her first experience with Dr. Acker when she had those maxillary molars removed. He was recommended to her because he was on the panel which the insurer listed for her parents, and she was still covered under her parents' insurance. She had surgery, labeled S, plus a miscellaneous assortment of dental procedures, totaling 6, including the surgery. The surgery was the first procedure. Mrs. Webb had 21 procedures in total, some surgeries, some other miscellaneous dental procedures. Patient C, who incidentally is a male who admitted to drug use and multiple heterosexual encounters, but whose viral DNA definitely matched that of these other patients and the dentist, had 14 patients, including surgeries and routine dental procedures. But here are some very mysterious patients, E and G, E a female, G a male. G had a total of 2 procedures, and simple endodontic procedure in week 1 and a restorative procedure in week 2. And E had approximately 10 procedures, 1 endodontic, and a miscellaneous variety of other procedures. Now, I'm not a dentist, but these are not very invasive procedures, and they really challenge the imagination when we try to think about how this terrible thing happened. This case has been investigated up and down and around and sideways. It was investigated by the Centers for Disease Control. It was investigated by the Florida Department of Health and Rehabilitative Services. It has been considered by the national laboratories in Los Alamos. And there are only 2 basic ways in which this horrible thing could have happened. One is that there was a direct blood-to-blood contact between the dentist and the patient. And you say, 5 times this happened? How could that have happened? Well, the pros of this are that he did do surgical procedures in at least 3 of these patients. And an endodontic procedure might be considered marginally invasive. One patient is known to have received care before the dentist routinely wore gloves. But against this theory is the fact that 3 of the patients absolutely swear that he wore gloves consistently through their dental treatment, and none of the patients remembers any incident that could explain, any emergency, any cuts, any time that he changed his gloves, that could explain their infection. Well, what's the explanation? The other possibility is that there was an indirect